This is Dr. John Bennett, broadcasting from Miami. Tonight we have the pleasure of having three Brazilian doctors, and they're led by Marco Andre Costa. Marco is, I believe, an ENT doctor that specializes in ENT cancer, and he's going to lead the proceedings. Also have, he's going to introduce Luis and Julio. Okay, Marco, it's all yours.
Okay, John, thank you for the presentation and the opportunity. This is the first OncoPedia TV show, and we have the pleasure to present Dr. Luis Araújo. Dr. Luis is a very skilled guy. He now works in Ohio, Columbus, and he very focused in lung cancer. In the next minutes, in the next 1 hour, we're talking about some molecular aspects and new discoveries that he's involved in. And we have the pleasure to have the very important present here, Dr. Julio Pereira. He's a neurosurgeon. He's specializing in radiosurgery, and we'll talking about then. This will be a very soft talk. The next 1 hour regarding lung cancer. Luis, thank you for being here. Could you present yourself and talk to us a little bit about your work and your team work in the next steps of your work there in Ohio, please?
Yeah, sure. Thank you, Marcos, for the invitation. Thank you, John, and also Julio for inviting me to participate. And just a quick background, I'm a medical oncologist from Brazil. I actually worked at the Brazilian National Cancer Institute with Marcos. And right now I'm working as a postdoctoral researcher here at the James Cancer Center at The Ohio State University. And I think we can talk a little bit today about the molecular tests and how the new tests for sequencing, especially next generation sequencing, how they're changing the environment of lung cancer, how we deal with patients nowadays, the plethora of options that we have, not only to better understand the biology, but we can better classify patients nowadays and really move to a personalized medicine era. And I think that's the goal for my goal for this event tonight with you guys.
Excellent. And Julio? Could you present yourself again?
Hi,
and,
how are you?
The role of neurosurgery in lung cancer, please.
Yes. Hi, how are you? My name is Julio. I'm from Neurosurgical Blog and Neurosurgical TV. And now, today I will learn with Luis and Marcos a little bit about oncology. So, that's all.
Okay, John, would you like to talk something? We can go on here. I think that we had some problems with John, but let's go on. And Luis, what the new discoveries and the new advances that we have seen today in lung cancer regarding molecular aspects and the new discoveries in mutations, and how this could impact in the clinical practice here in Brazil, in United States, and all over the world?
So, a quick background. As you know, lung cancer is a killing cause of cancer worldwide, right? That's the situation in the United States, that's the situation in Brazil. It's the #1 cause of cancer death, and about 85% of cases are classified nowadays as non-small cell lung cancer. And that's where the major advances have happened in non-small cell lung cancer. Non-small cell lung cancer is nowadays divided histologically as adenocarcinoma, the most common histology subtype, followed by squamous cell carcinoma, large cell carcinoma, and other subtypes. So the big discovery came about 2004 when EGFR mutations were first defined. Back in 2004, there were 2 drugs in development in lung cancer, which were erlotinib and gefitinib. As you know, those are nowadays called as the first generation EGFR TKIs, or tyrosine kinase inhibitors. And at that time, we had very low number of patients responding to this kind of drugs. So the response rate was about 5 to 10%, and nobody had a very good idea of what was going on with these patients. Why were some cases responding so dramatically, while other cases had absolutely no effect? And about 2004, we became aware of these EGFR mutations. So these EGFR mutations happen in about 10 to 15% of cases in Caucasian patients, like in the United States, in Europe, and mostly cases in Brazil. But they can be as high as 50 or 60% in some places like East Asia. So China, Korea, Japan have been reporting this kind of frequencies dramatically high. And these patients with EGFR sensitizing mutations, they have dramatic responses to these inhibitors. Following EGFR, and we can talk about second, third generation of inhibitors as well, but following EGFR, about 2008, 2007, we became aware of some fusions in a gene called ALK, or ALK. Especially the first fusion found was EML4 ALK. Came about 2007, so some years ago, and there was actually a drug named crizotinib, which is not ideal drug, but it's an ALK inhibitor as well as a MET inhibitor. And as far as ALK fusions were found out, researchers doing phase 1 trials with crizotinib started enriching these phase 1 clinical trials for ALK fusion tumors. And the response rates were dramatic again. So only a couple of years after the discovery of ALK fusions, we're having clinical trial, a phase 1 trial, published in New England Journal of Medicine, showing dramatic response to crizotinib in lung cancer, especially lung adenocarcinomas that present with the EML4 ALK translocations. So after that, we have nowadays at least 2 genes that are standard of care in the clinical settings. So every lung cancer, especially lung adenocarcinoma patient that presents to the clinic nowadays are being tested for EGFR sensitizing mutations and for ALK fusions. And we are also moving to widen this a little bit, because we've learned that some other histological subtypes, like large cell carcinoma, may also be presenting the same kind of mutations. So nowadays we tend to test every non-squamous cell carcinoma for at least EGFR and ALK fusions. And as I said before, we have fantastic drugs to treat this kind of patients. I don't know, Marcos, if you want me to go ahead or if you want to stop a little bit and discuss something. I think we lost Marcos now. John, can I go ahead? Do you have any questions or?
Yeah, Luis, I can hear you. You can go on.
Okay. Yeah. Okay, so this is the background. Okay, so this is the background. We have EGFR mutations, we have ALK fusions, and we have fantastic drugs for these samples, for these patients. Moving beyond EGFR and ALK, we nowadays have some newer genes that only mostly academic centers are testing. So academic institutions tend to have a very wide test for non-squamous samples. And there are different platforms to test this kind of samples, going from multiplex PCR sequencing, like we have Snapshot, we have Sequenom, These are tests based on PCR, so polymerase chain reaction. So it's basically a combination of different primers that can detect some specific hotspot mutations. And these tests tend to include at least 10 genes up to about 50 genes, but mostly for hotspots. So you can detect the hotspot position in EGFR, hotspot positions in other genes like BRAF, RB2, PTEN, AKT1, KRAS, NRAS. So you have a long list of genes. And the third generation of tests, so the first generation was Sanger sequencing, only one gene, one hotspot. Moving to second generation of tests, which would be the multiplex PCR snapshot and Sequenom. And nowadays we have the next generation of tests, which is the NGS, or next generation sequencing, which I prefer to call massively parallel sequencing. So with massively parallel sequencing, you can do whatever you want. It's basically, you can go from hotspot sequencing up to whole exome sequencing, whole genome sequencing, whole transcriptome sequencing, depending on your background of bioinformatics and your kind of lab support that you have to provide this kind of tests. So yeah, so with this kind of ideas, you can test those kind of genes, but you can also test some other stuff that's coming out. Yeah.
Well, you know, I have a question, Luis. I'm sorry.
Yeah.
I'm sorry about the technical difficulties. Well, but we'll get better. I was daydreaming, I think. But Luis, you know, one thing that I get from what you said so far, because I'm a regular doctor, I don't know much about cancer drugs at all. But my impression was that lung cancer was really not treatable. You were kind of stuck with it, and you were unlucky, and there wasn't much that drugs could do. But from what you said, it seems that it's fairly optimistic. Is that true? Is that true?
That's absolutely right. So back in 1985, right?
Mm-hmm.
There was basically no option at all.
Right.
That's when the first chemotherapy agents were coming out, and that's when we started doing, not me, but that's when it's being started to use the platinum-based chemotherapies.
Okay.
And people started to see responses. So about 30% of tumors are going to shrink. Patients are going to feel better because if the bulk of diseases is shrinking, the circulating cells are coming down, cytokines related to cancer are coming down, so you tend to feel better, so the performance status goes up. But that's very transient response. Chemotherapy leads to transient responses, and the median survival was about 1 year.
Okay.
With the discoveries of the subtypes of lung cancer based on the molecular profile, now we started to discover subsets of cases like EGFR mutants, where just a single oral drug is going to guide these tumors to control on average for 1 year. Average.
Mm-hmm.
So we are seeing now patients, I mean, I've had that kind of patient for 4 years under treatment with erlotinib. So it's 4 years with a deadly disease absolutely under control with no chemo. We're talking about oral drug. Very moderate toxicity, no hair loss, none of these things. So it's a completely unimaginable era. And the exciting point about that is not only that we found 2 cases, is that we have a plethora of genes that are underexplored. So let's talk, for example, BRAF. BRAF, about 3% of lung adenocarcinomas are going to harbor a BRAF mutation. So we've learned from melanoma that about 50% of melanomas have a classic mutation in BRAF in a position called V600. This kind of mutation in the lab is proven to be a cause of cancer.
Okay.
And this kind of mutations cause a dramatic dependence of the tumor on this kind of mutation. So it's like a cancer with a single leg, and if you break that leg, you can't stand anymore. So we have drugs against BRAF, like dabrafenib, vemurafenib, and these drugs are now standard of the art in melanoma. So if you find a melanoma with a BRAF V600E mutation, you give vemurafenib or you give dabrafenib, and that's a dramatic response. So about 3% of lung adenomas have BRAF mutations.
Mm-hmm.
And in phase 1 to phase 2 clinical trials, we are seeing as dramatic responses as we saw in melanoma. So we are probably going to have BRAF as a standard of care in the next years. So we found about RAT fusions. RAT fusions are being discovered in about 1 to 2% of cases of lung adenocarcinomas. Again, it's a very tiny number, only 1% of lung cancers, but 1% of or 2% of lung cancers are going to give a higher number of patients than any leukemia in the world, right? And we're excited in leukemias because we can give imatinib for CML, and patients are under control for a decade.
Mm-hmm.
So we're talking about 1% of lung cancer. We're talking about a higher number than CML, for example.
Excellent, Luis.
Right. So we found about RAT fusions. Okay, let's talk about RAT fusions. RAT fusions are present in about 1 or 2% of lung adenocarcinomas, and we know that we have drugs against RAT, right? We have cabozantinib, we have ponatinib, we have drugs being developed about RAT. We have RAT fusions in thyroid cancer, right? We have RAT fusions in thyroid cancer. We have RAT mutations in medullary thyroid cancer. And this kind of drugs, cabozantinib, is approved for medullary thyroid cancer, exactly because of these fusions. So in a phase 1 clinical trial, we had the first 3 patients enrolled, 2 of them dramatic responses with RAT fusions. So it was the fastest publication from the discovery of a driver alteration to beginning a clinical trial and getting the paper out. 3 cases included, 2 cases responded, cancer discovery. It's a AACR journal. It's a standard of the art journal in translational oncology. So again, very exciting, very exciting. ROS1 fusions. Somebody found about ROS1 fusions, right? Again, 1 or 2% of lung adenomas are going to have this kind of fusions, ROS1 fusions. But crizotinib, the same drug that acts against ALK, have some kind of dirty activity on ROS1. Okay, so let's try crizotinib on the lung patients with ROS1 fusions. Dramatic responses, dramatic. The tumor shrink and is under control with an oral drug. No chemo, no hair loss, none of that, right? And again, people are finding out about N-track fusions. There are drugs against this pathway. They are called the TRAC inhibitors. So people are trying nowadays TRAC inhibitors in lung cancer patients harboring N-track fusions. NR01 fusions, brand new. Again, being tested for drugs. And again, I have a long list of genes here. I have RB2 insertions. We have in the exon 20, there are some insertions in RB2, and there are dramatic responses to other ERB2, both monoclonal antibodies or inhibitors, right? So we have drugs approved for especially breast cancer. And you go from there, MET inhibitors. MET inhibitors, okay. MET amplification. We've learned that MET amplification is present in about 1 or 2% of lung adenos before treatment. Okay, that's very low baseline expression, amplification. And when I talk about amplification, I'm not talking about mutations anymore. Now we're talking about a higher number of copies of that gene. Okay? There are several explanations why a gene or a full part of the chromosome, when it's under mitosis, the correct mitosis will give you 2 copies. Everyone has 2 copies of every gene. But for some reason, this kind of genes can have 4 copies, 8 copies, 10 copies. So it's like the same gene with a higher factory producing the same protein. So you tend to have a very high expression of MET. And we know that crizotinib, again, crizotinib has an activity against MET. And it's been shown that if you give crizotinib to patients with very high copy number of MET, you tend to have very good responses. Also, MET, we've just learned about 2 years ago that we have some very rare mutations in RET in the codon 1003, and we also have some alternative splicing in MET. And these changes are known to cause colony formation in cell lines. So they're probably going to be proven as driver mutations, and they are probably going to be useful to target therapy in the near future. Yeah, I think I've told a lot of stuff about what's going on in.
Yeah, it's fascinating. I'm sorry, Marco, you going to say something?
Yeah, in resume, we think that there was a very important shift in the treatment of lung cancer in the last years, as Luis told for us in a very excellent way. I think that the most important mutations in the clinical practice are EGFR and ALK translocation and EGFR mutation. But we know that there are ERB2, BRAF, MET, ROS1, RET alterations in adenocarcinoma, and all these alterations that Luis told for us is he's talking to adenocarcinoma, not squamous cells. There is a difference, a separate entity. But my question to Luis is to know, in his clinical practice in Ohio, in the upfront approach to the patient with adenocarcinoma, I'd like to know if he tests all these alterations, all these mutation, translocation, amplification in the upfront treatment, or just EGFR and ALK mutation or translocation like we do here in Brazil. We do not test upfront ERB2, MET, ROS1. Just in the it is a next step in the treatment. It's not usually common and diffused, all the stats here, but it's very common to test EGFR and ALK translocation here. But I would like to know if it's common to test all these alterations up front in Ohio.
Yeah, that's a good question, Marcos. And the only reason not to test everything is because of the price, right?
Right.
If it's affordable to test everything, we want as much information as we can. So what we do here, actually, we test everything. So with the next generation sequencing platforms becoming more established, and I'd like to point that it's an academic institution. right? It's not, and as I said before, academic institutions tend to have so much clinical trial options and drugs coming out that you usually can take more advantage of testing more things. If you're not in if you're in a community center, you may be testing for a lot of stuff that you have no idea what to do.
Great.
But,
and Luis,
yeah.
You receive a patient with EGR mutation. This is a sensitive mutation, 18, 19, and 21. In the exons 18, 19, and 21. Yeah. I think that's like Brazil and all over the world. We can start EGFR inhibitors like erlotinib, gefitinib, and more recently afatinib. But I would like to know in your center there in Ohio, after disease progression of one of these TKI inhibitors, what options, treatment options do you have there? And Clovis compound, afatinib plus cetuximab, and or clinical trial. What's your clinical practice there?
So nowadays we have three drugs approved as first line in the U.S., right? You have erlotinib, you have gefitinib, and you have afatinib. Afatinib just showed a dramatic improvement in overall survival, not only progression-free survival, but also overall survival. So the trend nowadays, as possible, we try to rebiopsy patients in the second line. We've learned in the last years that there are many causes of resistance to EGFR TKIs. So the first idea, the first thing we have to remember is that some cases, sometimes the progression is so slow that the patient is not being affected by a slow progression, right? So if you see that on the CT the tumor's increasing, but it's slowly increasing, the patient feels just fine. I mean, there's no reason to add any other drug or change treatment if you feel like it's going fine. And we're clinicians, right? We don't treat CTs. So if the patient is just fine taking the oral drug, we just keep the oral drug. So you talked about afatinib plus cetuximab. So the combination of afatinib plus cetuximab tends to be more active in the patients that develop a T790M mutation. So we tend to rebiopsy and resequence these patients at progression when you're considering a second-line therapy.
Okay.
So if they have T790M, we tend to give afatinib plus cetuximab. But you also have the third-generation drugs coming out. You mentioned Clovis, but there's a Japanese compound as well, showing 90% response rates. So ideally, if you have one of these compounds in clinical trials, that's the first option, right? So third generation in clinical trials, first option. Other than that, afatinib, cetuximab, or switching to chemotherapy.
Excellent. And do you use PET scan as the his-stage exam and radiologic exam for all patients, or just tomography?
CT, only CTs. Okay. Yeah, one option to use the PET scan is if you're considering a local therapy. So if you're considering local therapy, let's say you have a patient with 5 lung lesions and 4 of them are under control, and you have 1 of them growing faster. So PET-CT can help you define if there's any other spot that you didn't see before. It can help you, the radiation oncology, better delineate that growing tumor. And then you can frequently treat only that hot spot and just follow up the other lesions and keep going with the TKI, right? But we don't use PET scan for follow-up.
And what about that recent trial that associated chemotherapy to TKI inhibitor? What do you think about that?
The trial was negative, right?
Okay.
I don't have the numbers here, but I mean the trial was negative. So standard of care, there's no reason to continue with erlotinib. When you decide to add chemo, it's basically a switch decision, right?
Okay.
TKI.
Excellent.
Yeah, unless it's a patient that developed some kind of flare. The flare is very rare, but if it's clinically visible that the patient's presenting a flare, you need to get erlotinib back.
Okay.
I have a,
okay, John, go ahead.
yeah, just a question, and this probably is addressed to all you guys because you're much younger than me. But I know you have there's a lot of talk about genomics and genetics profile and mutations. You know, that kind of talk I don't think was around when I was training because genomics was not a part of medicine like it is now. Now, do you guys undergo, and this is for you too, Marco, do you guys undergo training in genomics during your rotations, or how do you pick up the genomics?
I think that there are a few centers here in Brazil that has a genomics and molecular training. I think that National Institution that Luis belonged to it as me some years ago. We have a very advanced center with very skilled people focusing in molecular and genomics. Mm-hmm. But I think that this is not the reality of all Brazil. Brazil is a very heterogeneous country.
Okay.
And the main formation of the clinical oncology in Brazil is focusing in clinical patients, and unfortunately we have this approach in Brazil. The molecular approach is not very common here.
Okay.
Yeah, well, I totally agree with Marcos. We're about of the same age, and we're both trained at the Brazilian NCI. So I mean, we have the some kind of background. I mean, we read the same books that everybody else reads, mm-hmm. And I mean, in the last years, it became routine. I mean, you're going to see lung cancer patients, and you're going to have to decide therapy based on EGFR. It became available in Brazil in the past 4 years, so there is always a delay between US and countries like Brazil. But nowadays, if you go to the lung cancer outpatient clinic in the Brazilian NCI, you're going to see you're going to deal with EGFR mutations all the time. And every time you see classical mutations, easy to decide, and atypical mutations that you have not a clue what to do, and then you have to go to the website and figure out the best.
One quick question, Luis. If you have a patient, and you too, Marco, if you have a patient that presents you work up the patient and you find out they have, say, adenocarcinoma of the lung, how soon do you do genetic testing in Brazil, Marco? Do you reserve it for special cases?
Great, John. It's a very important question. I think the very beginning, it's very soon. The first option in my clinical practice is to test EGFR mutation, and for a very practical reason, I test together our translocation because sometimes we don't have enough material to test one and another and the other in sequence. And I usually test together to not waste material. And sometimes I had patients that I tested EGFR mutation, and I didn't have any more material to test self translocation, and I needed to have biopsy the patient. It's not unusual.
Mm-hmm.
This is my practice, and I really prefer to, and all the world prefer to start EGFR inhibitor if the patient has 18, 19, or 21 exon mutation. But my question to Luis, and in using this, the John question, is to asking him if the patient has 20 exon 20 mutation, this is a resistant mutation, and has a sensitive mutation like 18, 19, or 21. Do you yet prefer to start EGFR inhibitor? I prefer. We know that the time to progression of this patient is it's below the average of the patient, but I really prefer. And you, Luis?
Yeah, I agree. So what Marcos is asking is sometimes you have more than one mutation in EGFR. Mm-hmm. So I've been talking about the sensitizing mutations. The two classic sensitizing mutations are the exon 19 deletions, and patients with exon 19 deletions respond dramatically. The second mutation is L858R, which is in exon 21. So this mutation is also sensitizing. It's not as good as the exon 19, but the response is also huge. There are also some other mutations like G719. This is a sensitizing mutation, but it's called an atypical sensitizing mutation. So the response is not as good as with the exon 19 deletion. But we have some mutations, especially in the exon 20, and the classic one is T790M. So the T790M is a classic resistance mutation, right? So this kind of mutations sit as a gatekeeper, so they prevent erlotinib. They change the protein structure so that erlotinib cannot bind to EGFR. And not being able to bind, it doesn't work. So, but when we have double mutations, and that's what Marcos was asking, most of the studies show is that you have a borderline degree of response. Maybe it's not 1 year, maybe it's not 2 years, but you can sometimes control the disease for 6 months. And the reason may be because you may have different clones inside the same tumor, right? It may be that some clones are going to show the sensitizing and they are going to shrink, while other clones are going to have the resistant mutation and they are going to not shrink. So, but what we do is exactly that. We challenge the tumor. So we tend to try the drugs, and usually you have a better response than what you would get with just the chemotherapy.
And Luis,
yeah.
Sorry. In the setting, in the setting of the patient that that have a very good response in all lesions except 1 or 2 in the line. What is your option? Your practice? You stop the TKI you start you maintain the GFR TKI and use SBRT, for example, or surgery. How do you see that?
Are you asking after progression to a first-line TKI?
Oligo progression.
Yeah. So the idea is to treat whatever is growing, and there are some different not a guideline, but some ideas of what's the limit of what's the concept of oligometastasis, of oligoprogression. So let's say you have one single tumor growing. I mean, it's clearly an oligoprogression. You treat that piece of tumor, you operate that out, you irradiate that, you ablate that, whatever you do, but you treat that locally, and you keep going with the TKI. The concept of oligoprogression can be discussed. Some people say up to 5 lesions. Depends on if you have progression in the central nervous system and outside of the central nervous system. So the concept can vary, but the idea is you treat it locally and keep going with the TKI. You don't add anything else.
Sorry. Great, Luis. Let's talk about brain metastasis, Julio.
Okay.
We know that lung cancer has a very it's a very high incidence of brain mets, and you as a neurosurgeon, is there any particular challenge regarding lung cancer, brain metastasis, or how do you see that?
Okay. Radiosurgery is a new procedure, especially here. So we are growing knowledge about this. We know that radiosurgery work for small metastasis, and a few years ago we talked a lot about the number of metastases. If you has more than 4, you cannot do radiosurgery. It's a few years ago. Now it's not a rule. So you can treat multiple metastases, and usually depends the subtype. Some kind of adenocarcinoma radiosurgery work well, but I never read separate paper about this. How radiosurgery work with adenocarcinoma. There is few paper talk about this. It's not the clinical trial as you has a lot in oncology. So we know that work, but we don't have a lot of information specifically for this kind of tumor.
Okay, I think that radiosurgery is a it's a very good option to treat brain metastases, and it's really a very practical option to whole brain irradiation that was very common until some years ago, but in the last years radiosurgery has acquired a very high importance here in lung cancer during brain metastasis. And it's a recent trial, Japanese trial, that destroyed some paradigms regarding the number of brain metastases, as Julio told us. Could you detail this trial for us, Julio? There is not a precise number of brain metastases to start to indicate radiosurgery.
Yes, few years ago we broke a lot of rules in radiosurgery. There is some rule that was very important for some guys, but nowadays not a real rule. First is number of metastases. If you try to find this information, all guidelines say number of metastases. You can do radiosurgery if the patient has less than 4 metastases. But indeed, that's not a rule. Other thing that was very, it's how radiosurgery working in brain metastasis, in different kind of brain metastasis. this specific question we don't answer very well. If you are looking for this information in clinicaltrial.org, there is some trial that's going about this, you know, but number it's not real important. It's important. It's more important about volume. And the other thing that is very important, you know, it's the oncologist. Neurosurgeon need to talk with oncologist. We have some patients, Mark, that we work together and we manage the patient together, and we discuss a lot about this, you know, this kind of patient, how it's work, how chemotherapy it's work well or not. We can try radiosurgery this patient or not. This patient, the radiosurgery don't work very well in some metastases. Now you need to do a whole brain. So we need to discuss together. In my opinion, I completely agree with Luis, because a few years ago we treat disease, you know, we treat lung cancer. Now we don't need lung cancer. We need to know more about this patient. Do you understand? So genetic test is very important. We need to know what this patient was treated. Do you know, sometimes we discuss it, this patient would be operated, but you talk me a little bit about the chemotherapy. It's a danger for surgery. We cannot stop chemotherapy in this case. So sometimes we have to do radiosurgery because it could be a case. Of course, there is not a perfect case for radiosurgery or perfect case for radiosurgery or perfect case for surgery. We need to discuss case by case. And in my opinion, it's not specifically with lung cancer. You know, all kind of cancer, we need to stop the guidelines sometimes and discuss specifically this patient.
Well, maybe there's no answer to this question, but do you treat and anybody can answer this, based strictly on the radiographic findings, or do you kind of go on the clinical findings of what the patient's like? Do you base your decision on one more than the other?
Yes, we have to discuss, you know, there is some characteristics that you put more, you know, you think that's more important to perform surgery, but sometimes the patient don't agree with surgery. We have to discuss about the risk, you know, you have to discuss about aging, because sometimes we have a lot of patients with more than 80 or 9 years old and begin to discover cancer. But sometimes this patient, you know, it's completely, he works very well. So it's not about age. Depends how this patient work, how he's feel. So it's difficult to, of course, in Congress, in conference, we talk generally about a case and clinical trial too. But day by day, you have to stop and talk about this patient.
And John, there is a very important point to observation to point out here is that it's not necessary to start whole brain or radiosurgery in the moment that is diagnosed and detected the brain metastasis. As Luis can talk to us a little bit more regarding this, but we have a lot of new drugs, and these new TKIs, new drugs have changed a lot our approach and way of think about brain metastasis, because many of these lesions can respond to erlotinib, gefitinib, and crizotinib, and the new generation drugs has a huge response rate in brain mets. It's very important. Also, the new generation of drugs like alectinib, soritinib, there are new ALK inhibitors. They have some activity in the patient that failed in the brain after crizotinib exposure. And the same we can talk about Clovis compound CO1686 that has already and has a huge activity in brain mets. Talk to us a little bit more about this, please.
Yeah, thank you, Marcos. John, what Marcos is saying is something really cool. Okay. There's a recent clinical trial showing that I mean, every stage 4 non-small cell lung cancer nowadays has an MRI, a brain MRI, which was not the case in the past. But nowadays we're picking is like 1 centimeter lesion, 1.5, less than 1 centimeter lesion in the brain, which, I mean, in the past we didn't have many options, and I mean, everybody's afraid of brain mets. So you would go ahead and irradiate, you would operate that out, and then you would start the systemic therapy. But this clinical trial showed that these oligometastases in the brain are okay if you decide to treat systemically first, and then just follow up those lesions, right? So it's okay to follow up brain metastases nowadays. And the second idea is some drugs, especially the TKIs, they are tiny drugs, and some of them can cross the blood-brain barrier. They can actually cause shrinkage of the tumors. So I'll give you an example. I've had a patient about 3 years ago in Brazil before coming here, and she was a never smoker, diagnosed with lung adenocarcinoma, and her tumor had a exon 19 deletion, classic deletion for erlotinib. But the MRI came with 11 brain mets, 11. And she actually had some paresia of the left side, and she had a little headache. So we controlled the headache and the neurological symptoms. Are you listening, Julio? That's an interesting case. So we controlled the symptoms with steroids and decided to start erlotinib, first line. We didn't give radiation. We started with erlotinib, and we have the MRIs like 1 month later, clean, absolutely no lesions, absolutely no lesions. So that's only one of the reports that we have with this kind of responses. It's important to remember that crizotinib, the ALK inhibitor, is not very active in the brain, but the second generation inhibitors are very active. So ceritinib was just approved by FDA. The clinical trial is published at the New England Journal of Medicine. So ceritinib has a lot of activity inside the brain for ALK. And EGFR inhibitors, I think most of them are active in brain metastases, as far as I can remember. So that's also an option nowadays.
Okay.
Very interesting. Of course, it's very new, you know, and as neurosurgeon, it's so hard to follow up brain metastasis because our papers, you know, all the time we discuss about the possibility of, you know, radiosurgery, microsurgery, but it's hard to talk about the chemotherapy and just follow up. But of course, we have to learn to improve our skills, and we know, you know, it's if you have these options, we know oncology patients, it's so hard to treat. So could be one interesting option. Of course, there is trial about this.
Yeah.
Julio.
Yes.
Julio, do you have any kind of limit to make the surgery in these patients through 3 brain mets, 4 brain mets, or depends on the how fit is the patient, the size of the lesions, the location of the lesions? What's important to you as a neurosurgeon to indicate the neurosurgery for brain mets? How many lesions, the location, I think. What's important to you?
Yes, the first thing that is very important to know is radiosurgery don't work for if the patient have a high ICP, you know, intracranial pressure. So neurosurgery work for this. If the lesion is growing, you have to operate. There is no question about this. Just surgery, you can take out this lesion. So that's the first step. The number of lesions, that's a huge discussion about this. In my opinion, depends the clinical conditions. Of course, usually there is a lesion that make symptoms, causes symptoms. So this lesion you have to operate.
Julio, would intracranial pressure be the only parameter by which you would decide whether or not to operate, or is there other things you look at
Yes,
before
there
you
is
operate?
symptoms. For example, if the patient has hemiplegia or hemiparesia, you have to operate. Radio surgery don't work.
Right.
Chemotherapy. It's hard to think that chemotherapy can't work in this condition. And the Marco asked about the number of lesions that you can operate. There is no a number. I never read really about this, but you have to think about the patient and how can you resolve this problem. Usually there is a bigger lesion that you have to operate.
Okay.
I think that you can operate the bigger lesion and make radio surgeon in the smaller one.
Yes. I saw sometimes, if you can operate it more than one lesion. Usually if you do just one craniotomy, but sometimes it's not common. You can operate, one, you can perform a surgery and after that do other surgery. But you have to discuss with oncology about this because we know oncology patient, you have to discuss about quality of life. And as neurosurgeon, you have to work together with oncologists and other.
Okay. And Luis, to have an advance or some news regarding leptomeningeal dissemination of lung cancer, we had that some years ago. We had the trial explaining for us the use of erlotinib in high dose, usually 10 pills in this setting. But I think that in my clinical practice, I really use metaxat, intrathecal metaxat. And what do you use, Luis?
Yeah. So the methotrexate would be ideal for non-mutant cases, right? That's what you're saying. For mutant cases, so the thing is, mutant cases, ideally, if it's a EGFR mutant, EGFR is going to work no matter what. So it's going to get to the brain, inside the brain or the leptomeninges, no matter what. Standard dose, high dose, it's going to be there. And I would say it's the only few chance that you have to get some real control. Other than a mutant case, I also use methotrexate. Not phenomenal. I mean, you get control for some months, but it's a very bad prognosis situation yet. So I don't have a medical response to you.
This is kind of a general question for anybody. Do you see like personalized medicine where someone's genetic makeup is known? Do you see cancer therapy getting a lot better than it is now, or you think there'll be just a small effect?
No, huge effect. Huge effect. As I was saying before, I mean, you have a plethora of drugs being developed. If you talk to any of the bio industry, the pharma industry, each one has hundreds of drugs under development. And these drugs are causing shrinkage in 1–2% of the cases. So you're never going to approve these drugs unless you find a subset unless you figure out what's the biological background of this 100%, of this 1 or 2%. and this should accelerate the discovery and approval of the drugs. There are drawbacks in that setting, because if you hyper select the samples in the very beginning of the drug development, so let's say you have drug A under development, and you figure out that drug A works very well for mutation A. So you don't know what is going to happen with drug A in mutation B, right? So we're kind of switching the way drug development happens nowadays. We're enriching a lot in the very beginning, and you end up with a very good drug for a subset, but you don't know what if other subsets could also benefit.
Mm-hmm.
And what's happening is that sometimes you learn in the lab first that drug A might happen in mutation C, and okay, so now let's start treating with some patients with mutation C and see what happens.
Mm-hmm.
Yeah, but I mean, no question. I mean, there's no personalized medicine without personalized tests.
Right. Well, gentlemen, I think we'll wrap it up. If it's okay with you, Marcos, do you want to say anything else, Marco?
Yeah, I just want to remember all members. I think that all of the panel members know that this is the November. November is the Lung Cancer Awareness Month. This is a international campaign from IAUT. In Brazil, is a very famous campaign from prostate cancer named November Blue.
Okay.
But I think that we cannot forget that lung cancer kills more than breast cancer, prostate cancer, and colorectal cancer, and pancreatic cancer together.
Wow.
Just to tell that in the United States there are 200,500 of new cases yearly,
Mm-hmm.
and almost 100,000 deaths because of lung cancer. In Brazil, it's around 30,000 new cases, and it's the leading cause of death in Brazil.
Wow.
Too. It's a huge problem, and we must let general people that tobacco smoking and exposure to tobacco smoking is the leading cause of lung cancer. It responds for 85% of lung cancer. It's the single avoidable cause more available to prevent lung cancer. It's the one shot, a very big result to stop smoking. It's a very, very important measure. And just to resume all this talk with this very skilled man here tonight, I think that lung cancer is a public health problem in Brazil. I think that this is true in the United States and all over the world. More than 1 million people die. 1 million people, 1.5 million people die all over the world from lung cancer. It's a very huge problem.
Mm-hmm.
The personalized medicine and oncology came to our clinical practice. The new frontier is immunotherapy. There is a very, very fast moving area inside oncology, and we talk little or almost nothing tonight, but I think that will be contemplated in the next OncoPedia TV shows.
Mm-hmm.
But the personalized medicine and oncology is the future. I think that Foundation One is it's a very important tool in my clinical practice. When we do not have any more options, I usually send the material, the pathologic material, to the United States to test more than 300 mutations and detect some mutations and some alterations that some available drugs can fit for. I think that Luis, in his talk, would talk very fastly regarding Foundation 1. And I think that the neurosurgery in my clinical practice is crucial. It's not unusual to have brain mets, and Julio is a very, very important partner in my clinical practice. And I thank for him for his loyalty.
Well, Marco, I really appreciate you coming out tonight because certainly we could all use a lot of education as far as doctors, as far as patients, and what you said about lifestyle, how your lifestyle affects getting one of the worst cancers there is lung cancer. It's your lifestyle. 85%. That's a pretty high number. Um, and I look forward to you having a lot more hangouts. And you're welcome to have as many as you want, or just once a week if you want. And Louis, you're always welcome, always. And you can start your own channel if you want. And Julio is a TV star, and I really appreciate him coming out and being with us small doctors because you always see him on TV. So
No way.
so thanks a lot, you guys, and I'll shut off the camera and we'll talk a little bit. There's someone that wants to meet you guys. Thank you very much.
Thank you, John.